So, sir, Dr. Sangamitra did talk about the fact that she felt that continuous feeding was better than bolus feeding when it comes to glycemic control. So, could you lay some insights on what she said, and we can probably discuss a little bit more on what is your thoughts about. I know every topic in nutrition has not much evidence, but we that's the reason that we have experts like you on board to understand, what would be the difference between continuous versus bolus feeding when it comes to nutritional empowerment and glycemic control.
Yeah. So that answer is very simple, and it has been known for 10 years now. ICU patients must never be bolus fed. It should always be a continuous feeding, as Sangamitra told us earlier, using a pump if necessary. If you don't have a pump, it's okay. It can be done with good help from the family and from the nurses also. ICU patients must be fed only continuously because bolus feeding is a nursing nightmare. The blood sugar levels go up and down, fluctuate a lot, and then short-acting insulin is given to cut it down. Then the patient becomes hypoglycemic. Remember that hypoglycemia kills the patient. It is lethal. Hyperglycemia is not that dangerous to kind of begin with in the short term. Also remember, many times it is the overcorrection of hypoglycemia that is related to mortality, just as overcorrection of hyponatremia is associated with mortality. And therefore, the short answer is we should always start with continuous feeding, always. Okay. Now, why is it that bolus feeding is more common in India? That is because the bolus feeding comes from the kitchen, which practice should be abandoned, as we have talked about repeatedly, not in the hospitals where the panelists are involved with, but in other hospitals. And because of that, large bore tubes are used. The large bore tubes are needed because it's a kitchen prepared diet with high viscosity, and also because it will not drip nicely through a small bore feeding tube. That is the reason why bolus feedings are used, and the bolus feedings results in a huge glycemic variability, so it should not be used. Now the next step, Sanjit, after you are sure that the continuous feeding has worked very well, is to change it to an intermittent schedule. I agree with you that continuous feeding is very unphysiological, because you and I don't go run to the refrigerator every 1 hour at night. And when you feed the patient continuously, liver enzymes start going up. I agree. However, the lesser of the two evils is actually giving continuous feedings. And then you go to an intermittent schedule, 4 hours on, 4 hours off. Now, the benefit of intermittent schedule is, let's say that the feeding is supposed to be over by 12 and there is still some left in the bag, then the nurse will allow it to go a little bit longer. In other words, that there is a catch-up period. But the next feeding is started at the required time. So then you go on for 4 hours on, 4 hours off, and finally we go to a cyclical feeding. Now remember, along with that, glucose control becomes a big problem. That is where dietitians cannot get too involved with the medications, because there is a whole gamut of medications now available. And in the ICU, it is true that we can use usually insulin drip, but then we have to transition folks to subcutaneous long-acting insulin. And in the COVID crisis, we also learned that in stable ICU patients, glucose control can be achieved even with continuing oral medicines. In generally, Sanjit, we don't give oral medicines for ICU patients. But in stable patients who are not ventilated, giving oral medicines has worked during the COVID crisis. I won't recommend it routinely, but that option is available for stable patients. Over.
Correct. So what I do understand, and I actually use continuous feeding I personally use continuous feeding, but sir, I would point out to the fact that, as you rightly said, it's not very physiological to have continuous feeding. There is no doubt about it, and there are studies which actually say that if you were to intermittent feed them, the mesenteric arterial blood flow goes higher, there is an increase in peptide YY and a reduction in resting blood glucose. This is something that has been there for a while. And not only that, we also know that the whole body protein balance gets a little bit better when you actually give them intermittent feeding. That's there. But as you rightly said, it's a nursing nightmare. There's no doubt about it. You said the right word. It's a nursing nightmare. If I were to put my patients on intermittent feeding, I've got a lot of things that I need to do apart from just getting up the sugars and getting it down. And for the benefit of whoever's tuning into this, what we must understand is this glycemic variability, which is there maximally. It actually was not proven when it comes, because most of these continuous feeding and bolus feeding were actually done. These studies were done in neonatology. That's where most of these, in pediatrics is where these studies were done, which actually didn't effectively, or evidence based does not say that it changes the resting blood glucose per se. But however, we take the point that it is definitely difficult logistically to actually have bolus feeding versus continuous feeding. And rather, what you said in the middle, I just loved it. I mean, you just do 4 hours of feeding and go 4 hours of break. Probably that's the best of both the lots, where we would probably be able to catch up, at the same time reduce whatever the problems are, and in fact the lesser of both the evils. Yes, that's what I felt.